So I'll hand over to Arjun to get on with the evening. Thanks.
Thanks very much, Annie. So the first thing that we're going to talk about, I'm just going to give a real whistle-stop tour of why are we here this evening? Why is the CCG interested in diagnostics? What is the agenda? What's happening in the wider field? What's happening nationally? What's happening in London? And what we're doing about it. And it's really to give us a flavour of what's going on. And then we'll move on to try and really look at how it affects us in our day-to-day practice and what we can do together between primary and secondary care and between different secondary care providers, how we can really get diagnostics working for our patients. So we've given it a bit of a catchphrase, the right test at right time. We've got to think about diagnostics in context. It's an essential part of the patient pathway. We've learnt it from medical school, we've had it drilled into us, history, examination, investigation, diagnosis. So it's there from everything we do. And it's an unbelievably useful tool for a primary care clinician. We just want to graphically show that. You know, we have this huge cycle that goes round. The patient goes round through this machine. And diagnostics is a part of that. And we're going to just focus in on that component. But we've got to remember that where it fits in part of the whole experience that the patient goes through. So we're trying to get the right test at the right time to smooth that journey, and also to think that actually, you know, which test do I need now? Do I actually need to do more testing now? Do I actually need to do less testing now? What's my question? And some of this may lead to guidelines and protocols, but the point is we have to, these are to help us aid memoirs, not to stop us thinking as doctors. And we have to really use them as tools in that spirit in order to make the most effective use of the diagnostics facilities available to us in order to care for our patients. So why is the CCG interested in this? You know, why are we here this evening? A little bit is about money. It was taken on as a delegated budget for the CCG, and hence it's got our favourite acronym at the moment, a quick project attached to it, which meant I raised my hand up to take on diagnostics. And I thought, bright-eyed and naive as I was, that it was a perfect quick project from my vague understanding of it. This was 8 months ago. I thought we can get quality, get the right test, we can get innovation, we can get education. Pathologists love to teach us. We can get productivity. There's efficiencies in scale, there's efficiencies of working together, and we can prevent things. We can actually start looking at demand management. We can start looking at whole systems. How can we get the most effectiveness out of it? So that's how I came into it. How does it fit in the wider context? I'm not sure if people are aware internationally, there has been a move to centralising back office within diagnostics. Internationally, there are very, very big labs where people send their tests off and then they get the results back. In this country, Lord Carter did a review and recommended a similar project, but not quite to the scales that they're doing in Southeast Asia and our North American cousins. And in London, NHS London looked at the Carter report and have actually recommended a modernising pathology agenda, which recommends for each cluster to have a hub laboratory. And there are some loose timelines associated with that. And we've got to look at, actually, that's another process of reorganisation, it's another reconfiguration. We need to protect everything we can that we hold dear. And if we don't get involved, we're not going to have a voice in that. So how does it affect us in Ealing? And Ealing is an interesting case, as with almost everything that we talk about. We have quite a large number of providers. Once you go out of London, you don't normally have this kind of complex many-to-many relationship with people who can do your tests. We have the Doctors' Laboratory operating out of Ealing. We have Imperial, who are in themselves quite a complex organisation. We have North West London Hospital Trust, and we have Dhillion. So there's a large number of choices for us to send our pathology to. Just to put that into, I'm not sure how well that projects. Just to put that into geographical context, if you're more east of the borough, you may be sending stuff more to Imperial. If we're more central of the borough, we'll be sending stuff to Ealing, and people further to the west will be sending stuff to Dhillion. So we've got a broad range of providers, and how do we pull that all together? When we actually look at how we spend our money, I'll come back to spend. So what have we done in order, with all these changes that are happening around us, and with it being a QUIP agenda, what have I done in the last 8 months? First of all, we did a mapping exercise, basically a cost test analysis across our 5 providers, okay? And we looked at both costs of individual tests, and we looked at volumes. There were lots of issues with doing that. It wasn't particularly easy. What is an LFTs in Imperial may not match up to what an LFTs is in Ealing, and then you may get different prices. So it's quite complicated to do that. There was we did manage to struggle through that, and some of the results of that should be sitting on your tables tonight, showing you the range of how much things cost. We've started working to create a primary care formulary for pathology. So this was quite a big piece of work, and we're trying to align it to a national agenda about harmonising the names of tests, harmonising those reference ranges, and harmonising the way they're reported, the coding that come down to our systems. And so we looked at those, and we started looking at what tests do GPs actually ask for. You know, are they right? Are they wrong? Should we be working on it? Is there a big need of education? Let's start asking some questions of the information out there. And we actually started looking at how often should I be doing the thyroid function test? How often should I be doing the CRP? How often should I be doing a drug level? And we've started trying to pull together some guidelines that may be useful, and we hope to present those to you this evening to see whether they're right, and so we can get feedback and get them together. We've also looked at common things that GPs want to look at. Having a chest pain profile of groupings of tests isn't necessarily useful to us, but having a tired all the time, agreed set of investigations might be quite useful. And also we've done a bit of an educational needs assessment. The reason we're here on a Thursday night is because we've surveyed the CCG, and this was what we were told. The reason we're recording it is because we were told people want to have it recorded and be able to view it later so they can remind themselves. And I'm going to show you just a snapshot of some of the data we've got there. And we've also created governance structures. So this isn't just Arjun's ideas of how things should be. We've actually formed a group of GPs with secondary care colleagues from all our providers to actually agree that this is the right approach. And so we can stand up and actually say, why have you said I can't have this? We're not actually saying we can't have this. We're just saying, think before you go and you push for it. And that's all we're saying. So just to give you a flavour of the distribution of where the money's going, so we know where it's going. The big blue bit is TDL. The big red bit is Imperial, just in case you can't see it at the back. The green bit is Quest Diagnostics, which is West Middlesex Hospital, and the purple bit is North West London, so Norfolk Park. So this won't project very well, but this is the product of our mapping exercise between the different providers. This shows you the range of costs between all of those providers. We're not actually able to tell you directly how much a test costs because of some commercial sensitivities. It causes problems between the providers if I start publishing everyone all the explicit tests. But remember, this doesn't represent the whole cost of the system. This doesn't represent the cost of the phlebotomy, the bottles, the transport. This just tells us how much it costs for the processing of that test. And there's quite wide variation. So as a CCG, as purchasers for these things, we can then take it to our providers and have a meaningful dialogue to see how we can work with this. So just a bit about this idea of a formulary. We had a look with this is a lot of work from Frank Egan at Ealing, so a lot of credit has to go his way. We managed to get a long list of all the tests available throughout the system, and we're trying to maintain that in alignment with the national programme so that goes forwards. We then looked at what we were actually requesting, and about 398 tests were actually requested by primary care, not by the whole system. And we sat down, myself, Sandy, Guri, and Mark Spencer, with correlation with our clinical colleagues to look at where we should be looking at these tests and how appropriate they were. And we came down with a short list of about 200 odd tests that seemed like they were all the tests that we wanted to do. And also we highlighted areas that we want to move forward with educational and guideline development, and we seek to share that with you this evening and try and pick up more ideas from you guys to see how we can keep this agenda moving forward. We've also created these potential test groupings, which we've already given to TDL and are being implemented in an order solution. And we hope to get all the providers to align up to this so that we're doing things consistently across the patch. Oh, sorry, I'll be really quick. So this is just to show you the tail off. Actually, the vast majority of tests that we're doing are about 40 tests, and there's a very, very long flat tail where we're only requesting basically one every year, and we need to try and work out why we're doing those. This is just feedback from our educational survey. So we asked everyone, we got about 40 responses, and basically the response was we like Thursday evenings, and we'd like to have some videos, or preferably internet material to be able to follow this up. Sorry, I'm just going to skip through this because there's not much time. So really, how can we help our clinicians to... There's so much information now. How can we actually then take it out of the way? This is just a screenshot of Ealing's Electronical Questions system. Once we've got this formulary, once we've got these rules, once we've got these groups, we can turn them into tools to make it easier to remember. Because I can't remember it all. And actually, when I'm with the patient, what did we agree at that meeting? I can't quite remember. I don't want to look it up. But if it's embedded in my process, we can make it easier to be able to do the right thing as we've agreed together. I'm just going to skip through that very quickly. So, just going through where we're going to go next. So, we're going to start looking at diagnostics in context. So, we're going to have a short next door neighbour chat, trying to really tease out where there are problems so we can start capturing them. We're going to try and find out from Frank and Adnan what are the problems on the lab side. Can we start capturing those, and so we can start working through them? How can we get the best use out of the lab? And then hopefully we can work together to brainstorm and refine some of the groupings and some of the outputs that we've got together to be able to move forward.